Your blood pressure target is one of the most personal numbers in all of medicine. And if you're an older adult, it might be the most personal number of all. Because the same blood pressure reading can mean very different things in different people. What protects one person can actually be doing real harm in another. So in this video, I want to help you figure out your personal blood pressure target. And I'll walk you through the exact framework that I use with my patients in my clinic. And we'll go over the specific questions you can bring to your own doctor when you're trying to figure out yours. And if you're new here, I'm Dr. Leonid Kim, and on this channel, my mission is to give you the science and practical tools to not only live longer, but to feel better. And as always, even though I'm a physician, I'm not your physician. So please talk to your doctor before making any changes to your health regimen, as this video is educational only and not medical advice. So let's get into it. Now, there's a real disagreement happening between the country's top medical groups about what the right blood pressure target should be for older adults. The latest guidelines from the American Heart Association and the American College of Cardiology recently lowered their recommended targets. So they lowered it to 130 for people at a higher risk for heart disease or strokes, and even below 120 if possible, as an aspirational goal. But the primary care bodies, so these would be the American College of Physicians and the American Academy of Family Physicians, they've been historically more conservative in their blood pressure recommendations for older adults. So they still recommend higher ranges, anywhere between 135 to 140 and even up to 150, depending on the overall cardiovascular risk. So same population and largely the same evidence, but wildly different conclusions. And that's potentially a 20-point gap between what your doctor might tell you, depending entirely on which set of guidelines they follow. And even when the experts disagree like this, it's almost always a sign that the underlying evidence is more complicated than one number can capture. And in this case, that complexity all comes down to one major study. It's called the SPRINT trial. So SPRINT was this very large trial. It had over 9,000 adults with an average age in the late 60s. And in this trial, they randomized people into two groups. So one group was treated to a systolic blood pressure target of under 120. That was the intensive treatment group. And the other group was treated to a target of under 140. So that was the standard treatment group. And they got very interesting results. So the intensive treatment group, the ones that had the lower blood pressure targets, they had fewer heart attacks and fewer strokes and fewer cardiovascular deaths. And they also showed a 27% reduction in all-cause mortality compared to the standard group. Now that's a huge result, and that's exactly why the cardiology groups gave SPRINT so much weight in their new guidelines. But this is where things get more complicated, because other expert groups, like your primary care groups, they did not weigh SPRINT as heavily, and part of the reason was the fine print in the study itself. Because once you understand the fine print, the picture starts to look very different. So the first problem is who SPRINT did not include in the study. SPRINT excluded a huge chunk of the real-world older adult population. So they excluded people with diabetes, and no one with prior strokes, no one living in a nursing home, or anyone with significant frailty. In other words, SPRINT only tested aggressive blood pressure lowering in people whose bodies could actually handle it. But the exact people where this question becomes much more complicated were excluded from the study entirely. And then later we had a follow-up study, which was the ACCORD trial, which specifically looked at intensive blood pressure lowering in patients with diabetes. And in that study, they did not show the same clear benefit. So that actually raises a real question about how broadly can we apply SPRINT's findings. Because when someone says everyone over 160 should aim to get as close to 120 or even below 120, that's actually not what SPRINT showed. SPRINT showed that in healthier, more resilient, active older adults, aggressive blood pressure lowering can pay off, but only in that population. And another major issue was how SPRINT measured blood pressure in their participants. They used something called unattended automated office blood pressure, and those measurements read approximately 7 to 10 millimeters of mercury lower than typical measurements. Which begs the question, was SPRINT's target of under 120, did that actually correspond to a blood pressure of 130 or even 135 in real-world practice? And to their credit, the American College of Cardiology and the American Heart Association, they later acknowledged this, and they translated SPRINT's less than 120 target into a clinical target of 130 to account for that measurement difference. And then there's one more important detail that we have to cover. Sprint was actually stopped early because the benefits look so strong. But trials stopped early can sometimes exaggerate treatment effects. And in fact, a later Cochrane review flagged this as a concern, and they noted that Sprint's mortality reduction looked like an outlier in their own meta-analysis. Now, that's a lot of context around one study, but once you understand it, you start to see why different expert groups look at the same data and came away with very different recommendations. And this is not to say one group is wrong or one group is right. The fundamental tension is the primary care groups just weighed the harms of intensive treatments more heavily in older adults, while the cardiology societies, they've put more emphasis and they prioritize all the cardiovascular benefits of lower targets. So in a sense, both groups are correct. But what becomes really important in this situation is teasing out the correct targets for the specific individual patient. Every blood pressure target and treatment plan has to be individualized because there's definite trade-offs. So one of the biggest risks of lowering blood pressure too aggressively is falls, especially falls that lead to something like a hip fracture, because there's data that shows that the 1-year mortality after a hip fracture in an older adult could be as high as 25%. That's higher than many cancers. And once an older adult breaks a hip, getting back to where they were before is often extremely difficult. People are faced with months of limited mobility and loss of muscle and loss of independence. And falls are not the only potential harm. Pushing blood pressure too low can also cause kidney injury and syncope or passing out. And then, of course, there's drug interactions from being on too many blood pressure medications. And another underappreciated harm is cognitive slowing, where your brain is simply not getting enough blood flow. So this is where thinking gets slower and memory gets foggier. And that sometimes gets mistaken for early dementia when really it's just overtreated blood pressure. So the trade-off here is not a heart attack or a stroke versus nothing. It's a heart attack versus a hip fracture or a kidney injury. Or it could be a fall that results in something terrible like a brain bleed. But again, this does not mean lower blood pressure is bad, because for many older adults, it's exactly the right move to lower our overall cardiovascular risk. In the Sprint subgroup analysis, they actually specifically look at patients who were 75 and older, and even in this older group, intensive treatment still helped. They saw fewer heart attacks and fewer strokes and no significant increase in falls. So the answer was never back off in everyone over 75. The answer is match the aggressiveness to the right person. And for some older adults, that aggressive lowering is exactly right. So how do you actually put all of this together? Well, with my own patients, we still often aim for a systolic blood pressure of around 120 or even lower, but only if that person can actually tolerate it. And we individualize hard every single time. And then we reassess frequently. And one important note before I share my framework, this isn't medical advice specifically for you. This is just how I think through these decisions in my clinic, and if any of this resonates with you, this is definitely a conversation that needs to happen with your doctor. So the first thing we'll look at is someone's functional status. Can this person walk a quarter of a mile without any issues? Or can they climb a few flights of stairs? Or can they get out of the chair without help? Or are they active? Do they live independently? Because generally, the fitter and more resilient the person is, the more aggressive we can be with lowering of their blood pressure. And then we'll look at the overall medication burden. How many medications are they already taking? And what's the realistic risk of adding another drug to the mix? And then we also look at kidney function. And just as important, we need to look at the trend of the kidney function over time. Where was this person a year ago? Where were they 6 months ago? Where are they now? And if we try to move to a more aggressive blood pressure target, well, we'll have to monitor them more frequently. And then this part is very important. We have to keep track of their diastolic number very closely. That's the bottom number on the blood pressure reading. And this often gets overlooked. And the reason this is so important is because if the diastolic number gets too low, especially below 70 or 60, well, then the risk of coronary heart disease can actually go up. And that's because the heart's own blood supply, those coronary arteries that feed the heart muscle itself, they actually fill during the diastolic phase. So if the diastolic pressure drops too low, that can mean your heart is not getting enough of its own blood supply. And connected to this is something called pulse pressure, which is just the gap between your top and bottom numbers. So if your blood pressure is 140 over 80, well then your pulse pressure is 60. And as pulse pressure or that gap gets very wide, which can happen with aging, that can lead to stiffer blood vessels, which can then put you at a higher risk for cardiovascular events like heart attacks. So we always want to look at the full blood pressure reading and not just at the top number. And when you put all of this together, here's roughly where I tend to land on with the actual target ranges with my patients. And again, these are not prescriptive numbers for you specifically. These are just the starting points for a conversation with your own doctor. So for healthy and active adults between the ages of 65 and 80, with no red flags that we just talked about, we first discuss trying to get to a systolic blood pressure of 130. And if they tolerate it well, some people may actually benefit from going even lower to 120 or even slightly below 120 for that additional cardiovascular protection. But for frailer adults in that same age range, especially if there are mobility issues, or if somebody gets dizzy when they sit up or they stand up, or if there's underlying kidney disease, or there's multiple medications that are involved, well then the target we first discussed is usually closer to 140/90. Now, once someone is over 80 years old, this is where we really have to go very slow and we individualize very carefully. The target range there is usually between 135 to 145 systolic, but adjusted based on symptoms and tolerance. And then we have to be super vigilant and monitor for signs that we actually may need to back off from aggressive blood pressure lowering. So we'd be looking for things like feeling lightheaded or fatigue or brain fog and cramps or electrolyte abnormalities or worsening kidney function. The number one priority here is to avoid falls and injuries. So these would be the important things to discuss with your doctor if you're dealing with high blood pressure. And if you're already on blood pressure medication or two, do not stop medications on your own until you discuss this with your medical team. And the good news is blood pressure is one of the most solvable problems in medicine. There are lots of levers that you can pull just with nutrition and exercise. And if that's not enough, there's lots of great medications that work. The piece that sometimes gets missed is that individualized approach, where we'll look at your medical history and your mobility, your symptoms, and then using all of that information to figure out the target that works for you at the moment. I hope this was helpful. Stay healthy, and I'll see you in the next one.